Welcome to our video on congenital B-cell immunodeficiencies. Let's begin. In this lecture, we will go over X-linked agammaglobulinemia, common variable immunodeficiency, and selective IgA deficiency. For each topic mentioned, we will cover its definition, pathophysiology, risk factors, clinical features, diagnosis, and management. Let's begin with X-linked agammaglobulinemia. X-linked agammaglobulinemia is a congenital immunodeficiency disorder characterized by absence of mature B cells. Notably, the condition is also known as Bruton agammaglobulinemia. The pathophysiology of this disorder stems from an X-linked recessive defect in a special tyrosine kinase known as Bruton tyrosine kinase, or BTK for short. In simple terms, this defect leads to impaired B-cell maturation and subsequently decreased production of immunoglobulins. Importantly, most symptoms of X-linked agammaglobulinemia first manifest around 3 to 6 months of age. This is because maternal antibodies confer immunologic protection up until about 3 to 6 months of age. The primary risk factor for X-linked agammaglobulinemia is male sex, as this condition has an X-linked recessive inheritance pattern. The cardinal clinical feature of X-linked agammaglobulinemia is recurrent sinopulmonary infections, such as otitis media or pneumonia. The common culprits are typically encapsulated bacteria, such as Streptococcus pneumoniae. That being said, patients also tend to experience recurrent gastrointestinal infections, often due to infections with Giardia or Salmonella. Lastly, on physical exam, these patients almost always have either scant or completely absent lymphoid tissue, such as tonsils or lymph nodes. Here's an image of a human throat. Note that the uvula and the two tonsils on either side of it. In patients with X-linked agammaglobulinemia, the tonsils will usually be absent. The diagnosis usually begins with quantitative measurement of immunoglobulins, which will reveal decreased levels of all immunoglobulins. Clinicians may also obtain flow cytometry of a peripheral blood smear sample to quantify B cells and T cells. This study usually reveals nearly absent CD19 positive B cells and a normal to high T cell count. Finally, genetic testing may be obtained to confirm the diagnosis. Unfortunately, there is no definitive cure for X-linked agammaglobulinemia. Management usually involves lifelong immunoglobulin replacement therapy and periodic use of prophylactic antibiotics, especially if replacement of immunoglobulins is unsuccessful in preventing infections. It is also important to know that patients with X-linked agammaglobulinemia do not benefit from vaccines because they cannot mount an appropriate immunologic response. Moreover, live vaccines are absolutely contraindicated in these patients due to a risk of causing an infection. Clinicians should consider prophylactic antibiotics if immunoglobulin replacement therapy is unsuccessful at preventing infections. What are the similarities and differences in clinical presentation between X-linked agammaglobulinemia and transient hypogammaglobulinemia of infancy? Examiners will often pit these two conditions against one another on exams, which is why it is important to take a moment to write out the similarities and differences. Both conditions may present with recurrent sinopulmonary infections and low levels of IgG around 6 months of age. Patients with transient hypogammaglobulinemia of infancy, however, will have a normal B-cell count, a normal response to immunizations, and they often have some form of atopic disease such as eczema. Patients with X-linked agammaglobulinemia, on the other hand, will have a decreased B-cell count, no response to immunizations, and have no association with atopic disease. Lastly, as we learned on the previous slide, X-linked agammaglobulinemia is a lifelong condition requiring lifelong immunoglobulin replacement therapy. This is contrast to transient hypogammaglobulinemia of infancy, which, as the name suggests, is transient, meaning that the immunoglobulin deficiency will self-resolve and will not require any intervention beyond standard observation. Now that we've covered X-linked agammaglobulinemia, let's move on to common variable immunodeficiency. Common variable immunodeficiency is a congenital immunodeficiency disorder characterized by failure of B-cell differentiation. Specifically, mature B cells fail to differentiate into plasma cells, which leads to impaired production of all immunoglobulins. Consider this figure that depicts the basic steps that lead to production of antibodies. A B cell encounters an antigen and undergoes proliferation and differentiation to turn into a plasma cell, which in turn secretes antibodies like IgM. In patients with common variable immunodeficiency, B cells cannot differentiate into plasma cells, which makes them unable to produce antibodies. As such, these patients are considered immunodeficient due to their inability to produce antibodies. To this day, there are no known risk factors for common variable immunodeficiency, as its etiology remains largely unknown. The condition usually presents either during puberty or early adulthood. Similar to X-linked agammaglobulinemia, these patients suffer from recurrent sinopulmonary infections, such as otitis media and pneumonia, and recurrent gastrointestinal infections, often caused by either Giardia or Salmonella. Unlike X-linked agammaglobulinemia, common variable immunodeficiency is frequently associated with chronic lung disease, such as asthma or bronchiectasis, chronic gastrointestinal tract disease, such as diarrhea with subsequent failure to thrive, and autoimmune manifestations, such as thyroid disease or arthritis. Lastly, patients with common variable immunodeficiency have an increased risk for developing a malignancy, most commonly a lymphoma. When it comes to the diagnosis, quantitative measurement of immunoglobulins will reveal markedly decreased levels of IgG and decreased levels of other immunoglobulins, such as IgA or IgM. Importantly, these patients will often have a normal B-cell and T-cell count, but a decreased plasma cell count. Similar to X-linked agammaglobulinemia, patients with common variable immunodeficiency also require lifelong immunoglobulin replacement therapy, and they do not mount an immunologic response to vaccines. What are the key similarities and differences in clinical presentation of X-linked agammaglobulinemia and common variable immunodeficiency? X-linked agammaglobulinemia and common variable immunodeficiency may be easy to confuse on exams, which is why it is important to take the time to compare and contrast them. Both conditions are characterized by recurrent infections and decreased levels of all immunoglobulins. However, X-linked agammaglobulinemia is normally present by age 3 to 6 months, whereas common variable immunodeficiency usually presents during puberty or early adulthood. Additionally, patients with X-linked agammaglobulinemia will have a decreased B-cell count, whereas patients with common variable immunodeficiency will have a normal B-cell count. Remembering these key differences will be helpful in distinguishing these two pathologies on exams. Let's move on to discuss selective IgA deficiency. Selective IgA deficiency is characterized by a congenital deficiency of immunoglobulin A or IgA. Notably, selective IgA deficiency is the most common primary immunodeficiency in the world. The pathophysiology is straightforward. Plasma cells are simply unable to produce IgA. Aside from that, B-cell and T-cell function is largely normal. When it comes to the risk factors, selective IgA deficiency is more common in Caucasians and presents with a family history of selective IgA deficiency. Fortunately, most patients with selective IgA deficiency are largely asymptomatic, and they may even go their whole life not knowing they were deficient in IgA. That being said, potential clinical features of IgA deficiency include recurrent sinopulmonary and gastrointestinal infections, especially chronic giardiasis. This is because IgA is normally responsible for fighting off pathogens at the mucosal surfaces. Without it, pathogens are more likely to persist at the mucosal surfaces and lead to an infection. In addition to recurrent infections, IgA deficiency carries an association with autoimmune diseases, most commonly celiac disease, and an association with atopic diseases such as asthma or eczema. Lastly, patients with selective IgA deficiency are at an increased risk of experiencing an anaphylactic reaction to blood transfusions. This is because patients with IgA deficiency may develop antibodies against IgA, and these antibodies may trigger an anaphylactic reaction in response to IgA floating in the plasma of the donor's blood. Importantly, anaphylaxis in response to a blood transfusion is a common presentation of selective IgA deficiency on exams. In terms of the diagnosis, quantitative measurement of immunoglobulins will reveal an isolated deficiency of serum IgA in the setting of normal levels of all other immunoglobulins, such as IgG or IgM. As mentioned earlier, the function of B cells and T cells is not affected in this condition, which is why patients with selective IgA deficiency will have normal B cell and T cell count. The management of selective IgA deficiency is largely supportive, and may, for instance, involve treatment of recurrent infections. Otherwise, if diagnosed with selective IgA deficiency, patients are strongly encouraged to carry a medical alert bracelet to alert care teams about possible blood transfusion reaction. If a blood transfusion is absolutely necessary, clinicians should wash packed red blood cells prior to a transfusion. The term washing means removing plasma from packed red blood cells, and plasma is the component that contains proteins and immunoglobulins like IgA. Hence, washing packed red blood cells would clear them from any IgA, which would substantially decrease the risk of an anaphylactic reaction to a blood transfusion. In a patient with selective IgA deficiency, what are the main clinical features of an anaphylactic reaction to a blood transfusion? Since patients with selective IgA deficiency are at high risk of anaphylaxis following a blood transfusion, it is important to review the main clinical features that would suggest this diagnosis. Suspect anaphylaxis if patients rapidly develop angioedema or urticaria, respiratory distress, and shock within seconds to minutes of receiving a blood transfusion. Here's a table summarizing the most salient and high-yield concepts discussed in this lecture. You may find it useful to return to this table when reviewing the congenital B-cell immunodeficiencies before your exams. Let's conclude this lecture with a multiple-choice question. A 14-year-old boy is brought to the emergency department by his father due to cough and high fever. The boy says he's been coughing up yellow phlegm and has been feeling unwell since yesterday. Past medical history is notable for asthma, recurrent ear infections, and several episodes of giardiasis. Blood pressure is 125/82, pulse is 91, respiratory rate is 18, and temperature is 38.4 degrees Celsius. Physical examination is notable for increased work of breathing and crackles on auscultations of the right lower lobe. A chest x-ray confirms the diagnosis of pneumonia, and the patient is admitted for antibiotic therapy. Which of the following is the likely explanation for this patient's recurrent infections? A. Decreased T cell count. B. Impaired differentiation of B cells. C. Decreased B cell count. And D. Impaired maturation of B cells. The correct answer is B. Impaired differentiation of B cells. This is a case of a 14-year-old boy who was admitted to the hospital with a diagnosis of pneumonia. Notably, his past medical history is notable for asthma, recurrent ear infections, and several episodes of giardiasis. Given these clinical clues, the most likely explanation for his recurrent infections is an underlying diagnosis of common variable immunodeficiency. Recall from this slide that common variable immunodeficiency typically presents during puberty or early adulthood, and that it is associated with recurrent sinopulmonary infections and recurrent gastrointestinal infections, particularly due to Giardia and Salmonella. Also, note that these patients also often suffer from chronic lung disease, such as asthma or bronchiectasis. Hence, our 14-year-old with a history of asthma, recurrent ear infections, and recurrent bouts of giardiasis fits this clinical presentation quite well. Next, recall from this slide that common variable immunodeficiency is characterized by failure of mature B cells to differentiate into plasma cells, which impairs production of all immunoglobulins and creates a state of immunodeficiency. This is why option B, impaired differentiation of B cells, is the correct answer. Option A, decreased T cell count, is incorrect because patients with common variable immunodeficiency have a normal T cell count. Option C, decreased B cell count, and option D, impaired maturation of B cells, are both incorrect because they are features of X-linked agammaglobulinemia, not common variable immunodeficiency. This concludes our lecture on congenital B-cell immunodeficiencies.